And now, please welcome our first session chairs, Louis Roberts and Saravis Osatapal. And now, ladies and gentlemen, please welcome to the stage Adriana Gamboa.
Hello. Good morning, everyone. My name is Louis Roberts from the Mayo Clinic, and my co-chair is Dr. Saravis or Alm or Satafan. And welcome to this first scientific session of the day. And Dr. Satafan will introduce our speaker.
All right. It's my distinct pleasure to introduce Dr. Adriana Gamboa. She's an assistant professor of surgical oncology at the University of Texas MD Anderson Cancer Center and a graduate of Baylor College of Medicine with a master in clinical research from Emory University. She specialized in the surgical treatment of complex GI malignancies, including pancreatic, rectal, and hepatobiliary cancers. So Dr. Gamboa is a prolific researcher and is a multi-year recipient of the ASCO Conquer Cancer Foundation Merit Awards. Her work focuses on leveraging real-world data to map cancer trajectories and analyzing the molecular profile of young-onset cancers. Combining her background in bioengineering with advanced surgical training, she is dedicated to improving oncologic outcomes through multidisciplinary collaboration and personalized, compassionate patient care. Dr. Campbell.
Thanks so much for that introduction. It's such a privilege to be here today as a first-time attendee. This morning, I'm discussing a fairly broad series of topics regarding surgical principles, transplantation, and local regional therapy. But my goal is to really give us a practical, evidence-based framework for the management of this disease, and I'll highlight some of the discussion that went on yesterday and just rehash some of these topics. As always, there are three basic tenets that drive every decision. What is the anatomy? What is the biology? And what is the patient's condition? We'll keep the first two at the top of mind as we discuss these treatment strategies today. So starting with surgery. Before we get into specifics, I want to establish the surgical principles that underpin every decision that we make. First, an R0 or margin negative resection. Margin status is the single most important prognostic variable across all three subtypes of resectable disease, and all of the principles that follow are really in service of achieving this. Adequate lymphadenectomy, which is a minimum of 6 lymph nodes, is imperative for staging, and as we'll see, carries a potential therapeutic benefit in its own right. Vascular involvement does not automatically close the door. Sorry, slides just advanced here. Oh, got it. They're still on the right. Okay. So vascular involvement does not automatically close the door. And in perihilar disease, the caudate lobe is almost universally included, and routine resection moves R0 rates from around 60 to 80%. Adequate future liver remnant is imperative, and the threshold should be considered on the higher side for patients with cholangiocarcinoma. And finally, neoadjuvant therapy, which you heard about yesterday from Dr. Shisher Michael. There's no level 1 evidence yet for resectable cholangiocarcinoma, but in patients with high risk resectable disease, giving systemic therapy before surgery is becoming an increasingly rational strategy. So diving into the data for margin status, these are the results from a large multi-institutional retrospective series of resected hepatic cholangiocarcinoma. Survival is stratified by margin distance in millimeters. Two panels. On the left, you can see recurrence-free survival. On the right, overall survival. And critically, even the narrowest negative margin, which was 1 to 4 millimeters, outperformed a positive margin or an R1 margin in both recurrence and survival. So margins matter in intrahepatic cholangiocarcinoma. In terms of lymphadenectomy, I'm highlighting two key studies. On the left, we have an international multi-institutional study of resected intrahepatic cholangiocarcinoma, which established the staging imperative. 30% of patients who underwent a lymphadenectomy had nodal metastases. Median overall survival for N0 or node negative disease was 30 months versus 23 months for those node positive or N1 disease. So we know that nodal status changes prognosis because it allows adequate staging and guides perioperative therapy. The study on the right adds a therapeutic potential dimension. Lymphadenectomy resulted in a survival improvement. And I highlight the risk factors for having nodal disease, including the type of morphology of the cancer, the CA19-9 level. And these patients are the patients that may benefit the most from an adequate lymphadenectomy, so those that are higher risk. In terms of the lymphadenectomy that should be performed, there's some data to suggest one size does not fit all. Don't really need to get into the precise details. This figure from the previous study I mentioned can really be used as a surgical roadmap in terms of what lymph nodes are most likely to be involved and would be best for staging. And here's sort of the survival consequence of getting this right. This was a retrospective study of patients who underwent liver resection for clinically node-negative intrahepatic cholangiocarcinoma at tertiary referral centers. They then compared overall survival and recurrence-free survival of patients undergoing an adequate lymphadenectomy, again, 6 lymph nodes, versus inadequate lymphadenectomy. Here are the 4 overall survival curves stratified by 2 variables, adequate lymphadenectomy and nodal status. The top curve in blue is adequate lymphadenectomy and node-negative disease. And the key message here is in the separation of these curves, in that adequate lymphadenectomy and node-negative disease is a dramatically different survival trajectory than inadequate lymphadenectomy, regardless of nodal status. This was even more important in patients with less advanced tumors, sort of reinforcing that biology and surgical quality can compound one another, and you can control the biology, but you can control the dissection. Moving on to the importance of the caudate lobe, which is sort of the part of the liver at the basement, tucked in the back of the liver, and in very close proximity to the bile drainage of the liver. This 2021 cadaveric study of 25 cadavers showed 81 caudate bile ducts that they mapped. And the key anatomical finding was that caudate ducts drain directly and bilaterally into the confluence of the left and the right hepatic ducts. Interestingly, the data on routine caudate lobe resection for perihilar cholangiocarcinoma is sort of mixed. Here's a retrospective study out of the US Biliary Consortium where results noted that routine resection of the caudate lobe improved margin negative rates, which is a consistent signal across multiple studies, but it was not associated with any differences in recurrence-free or overall survival, likely reflecting perhaps that other margin sites may dominate the prognosis here, even when the caudate is cleared, and that systemic recurrence may limit the survival benefit of a local margin control in higher stage disease. The next principle that we'll discuss is the future liver remnant, which is the part of the liver that remains after surgery. In this well-cited study, they looked at 133 patients undergoing resection for hilar cholangiocarcinoma. 85% had preoperative biliary drainage, and 41% of those had cholangitis or an infection of the biliary tree. 22% developed major complications, and 10 patients died within 90 days, almost all from liver insufficiency. When they modeled what predicted liver failure, 2 variables came out on top. That was preoperative cholangitis and a functional liver remnant, or FLR, below 30%. It is the interaction between these 2 variables that matters most. When the FLR is less than 30% and the patient has had cholangitis, sorry, these slides keep advancing here. The rate of hepatic insufficiency was much higher. But when the FLR was adequate, essentially the effect of cholangitis disappeared. So the sequence matters. Drain the right lobe, resolve the cholangitis, confirm your FLR is adequate, and then proceed to resection. Outside of the technical aspects, I'm bringing back the concept of biological resectability. Highlighted here in this table are some of the key factors that are associated with higher risk disease. We know that a technically resectable intrahepatic cholangiocarcinoma with node positive disease and an elevated CD199 will likely recur in 6 months, half the time. So we know that biological high risk features equate borderline resectable disease. With this, I bring in the concept of neoadjuvant treatment, which you all have heard about yesterday. We understand the immunotherapeutic and biologic rationale for giving preoperative immunotherapy. First is the concept that the primary tumor is a rich source of neoantigens that prime systemic immune response. There's also the clinical argument that giving preoperative chemotherapy allows to evaluate response and test the biology of the disease. This brings us to NeoGAP, Dr. Meithel's trial, which you heard about yesterday, which was designed to evaluate neoadjuvant GAP in patients with resectable but oncologically high-risk intrahepatic cholangiocarcinoma. The study design was straightforward. This was a pilot study of 30 patients, and it was not really powered to detect a survival difference, as the primary outcome was really feasibility and safety of a preoperative regimen. You can see here the inclusion criteria of high-risk patients. And starting with feasibility, which was the primary endpoint, the data here are essentially as good as they get. All 30 patients completed their preoperative chemotherapy, and with 73% of patients completing all therapy, which again is a strong signal for overall protocol adherence. So now turning to the waterfall plot, which captures the radiographic response data. Each bar represents a patient. Bars going down represent tumor shrinkage. Bars going up represent tumor growth. And what you see here is a predominantly downward pattern across the cohort. The disease control rate was 90%, which is compelling and again demonstrating that we're not delaying surgery by utilizing a preoperative approach. Here are the survival data. We cannot definitively conclude from this data alone that neoadjuvant GAP improves survival. What we can say is that survival outcomes in those who complete the full protocol are encouraging enough to justify next steps and additional trials in this space. So switching gears a bit and moving on to transplantation, before 2010, intrahepatic cholangiocarcinoma was an absolute contraindication to transplantation. Early case series showed recurrence rates above 65%. But this was predominantly a selection issue, and early recommendations were not in favor of transplantation for intrahepatic cholangiocarcinoma. But this really changed in 2014 when this study came out showing remarkable outcomes with transplantation, again, in a really select group of patients. You can see here the selection criteria for transplantation for intrahepatic cholangiocarcinoma. On the tumor side, a lesion 2 centimeters or less, so very early intrahepatic cholangiocarcinoma, and select centers are extending this to 3 centimeters. And again, there should be no markers of any biologically aggressive disease. The patient, again, must be unresectable for some underlying liver issue, and there's typically some bridging therapy that happens during the waitlist period. When those criteria are met, the outcomes are really compelling with a 5-year overall survival rate of 60 to 89%. As far as transplantation for perihilar cholangiocarcinoma, we have the well-established NEO protocol that's delineated here, which is the standard of care at centers with the right expertise and volume of patients with a radial dimension of less than 3 centimeters. Outcomes, as you can see, are fairly robust, with a 68% 5-year overall survival and a 65% recurrence-free survival. And again, a 25% waitlist dropout, typically due for biologic reasons. So why does the 3 centimeter threshold in the eligibility criteria matter so much? This slide really answers that question. This 2012 study is the largest multi-center series on perihilar cholangiocarcinoma transplantation, where they looked at recurrence-free survival stratified by tumor size. At 5 years, you're looking at 69% versus 32%. That 3 centimeter cutoff really seems to be kind of the biological threshold at which the disease changes character, where locally confined perihilar cholangiocarcinoma transitions into something perhaps with a much higher probability of micrometastatic disease that the transplant cannot address. When comparing transplant versus resection for perihilar disease, we have this retrospective 2017 study that compared both interventions. On the curves on the left, you can see that a resection median survival of 21 months and not reached in the transplant population. The curves on the right compared transplanted patients to a really select cohort of patients with tumors less than 3% who had node negative disease. So again, in the most favorable of candidates, transplant still won. So prospective trials are needed in the space, but these data are quite compelling and form the basis of transplantation in cholangiocarcinoma. Transitioning over to local regional therapies for cholangiocarcinoma, in patients with advanced cholangiocarcinoma, systemic therapy is really the preferred treatment modality. However, based on some of the early studies, we recognized that the majority of patients progress locally or within the liver. Therefore, the concept of local regional therapies emerged, including TACE, ablation, radiation, HAI, and most recently, as you heard about yesterday, histotripsy. There are 5 real scenarios in which sort of liver-directed therapy or local regional therapy is typically considered, including an unresectable disease as a bridge to transplantation, in borderline resectable disease needing some form of downstaging, in patients who are not great surgical candidates, and in recurrent disease. Ablation is really the right choice in patients with small solitary lesions that are unresectable due to their candidacy for surgery. As you can see here, the ablation data is small but consistent across studies. The message is simply about, again, patient selection. If the lesion is under 3 to 3.5 centimeters, radiofrequency ablation achieves 100% technical success. Over 4 to 5 centimeters, success rates really drop. The Kim series on top really stands out with a 38-month median overall survival. These are essential surgical equivalent outcomes, again, for properly selected small peripheral tumors. If for some reason surgery is off the table, but the tumor is small, and again, peripheral ablation may be the right first conversation. TACE can be considered for larger unresectable intrahepatic cholangiocarcinoma, which again is not the topic of today's talk, but it is a form of local regional therapy that is used. The data for TACE in intrahepatic cholangiocarcinoma is predominantly retrospective and quite heterogeneous. There's different chemotherapy agents that are used, there's different patient populations, there's variable rates of extrahepatic disease, and median overall survival ranges from 9 to 16 months across series. The PARC comparison from 2011 is sort of the most useful benchmark. TACE median overall survival was 12 months versus best supportive care, which was 3 months, essentially a 4-fold survival advantage. The take-home point here is that TACE works best in hypervascular intrahepatic cholangiocarcinoma with liver-confined disease. Next is the hepatic artery infusion pump, and this is typically being used in unresectable disease or as a bridge to transplantation in some centers. Pump 2 is really the most important recent data in regarding HAI in intrahepatic cholangiocarcinoma. This was a trial of 50 patients with unresectable liver-confined intrahepatic cholangiocarcinoma. HAI was used plus systemic gemcitabine and cisplatin for treatment-naive patients. For their primary endpoint of 1-year overall survival, they achieved 80% versus a historical gem-cis control of 47%. And median OS was 22 months, which is pretty remarkable. Pump 2 is sort of a phase 2 study with a historical comparator, but these data have fundamentally changed how we think about HAI for intrahepatic cholangiocarcinoma. And this trial lands really in the context of major retrospective series looking at HAI and intrahepatic cholangiocarcinoma. This table here summarizes 9 studies, predominantly out of Memorial Sloan Kettering, with a median OS ranging from 20 to 39 months. The data here for HAI are consistent, and this should really be a tool that we offer to our patients. Looking at Y90, there's some useful applications to Y90. It can treat large tumors that are too big for surgery. It can treat clusters of tumors in one part of the liver. One particular interesting use is a phenomenon called contralateral hypertrophy. So when Y90 is used to treat one half of the liver, that side, the treated side, tends to shrink over time, while the untreated side can actually grow bigger. And for some patients, this creates an opportunity to make surgery possible. So this is really a good way to sort of use one modality of treatment to make another treatment strategy possible. And lastly, looking at SBRT, you all heard about this yesterday from Dr. Wu. While there's no level 1 evidence specifically looking at SBRT and intrahepatic cholangiocarcinoma, um, the field rests on a consistent retrospective dose response signal. And the practical reality is that intrahepatic cholangiocarcinoma mortality is driven by intrahepatic tumor progression, making local control by things like radiation really a rational treatment goal, and despite the absence of randomized control data here. This is a nice little schematic for how we can think of how we use all of these different modalities together. I think the most important thing is to really have a good team, multidisciplinary discussion with the patient always at the center of this. That's all I have. Thanks so much. Happy to take any questions.